So I just wanted to take this opportunity to talk to you all about water rescue and drowning. And there's a few reasons for that, partly because it is the time of year to get them, and lockdown's easing, weather's getting warmer, and in terms of Aeromedical, we're going to come on to the numbers later, but about 50% of our jobs in terms of drowning and water rescue occur in the months of November, December and January, so it is the time where we get an increase in the number of jobs. So it's partly that, but also in a bit of a selfish way. I've not done a water rescue before. I don't know if any of the registrars have, but it's a job where, which is quite unique to this service from a doctor point of view, and we probably haven't experienced it before. It's quite a specific type of job, and it's one, I don't know if you remember the new registrars from looking on the VLE, but it talks on the VLE about how this is the one job where we as the doctor have to be, I'm not quite sure the terminology, I can't remember the terminology, but we have to be quite independent and not reliant on the paramedics to hold our hands. So we have to essentially know what we're doing to be safe, because obviously the door's going to be back and we're going to be working with a sick patient and we have to be effective. And also it's a time critical job, so we need to know what we're doing so we can get these patients quickly and manage them effectively. So it's a job where we are big boys and girls and have to be able to act on our own and act independently. And so there's been a few questions that I've had, having not done one of these jobs, about how it might work. For example, do we go on wander lead? Can we open the DEA when the door's open? That sort of stuff. And I thought if I've had these kind of questions, then other people probably have as well. So hopefully we'll answer some of those ones. And then in terms of drowning, again, I hadn't actually seen a drowning patient pre-hospital when I agreed to do this talk. And I had a few questions about drowning in terms of, primarily in terms of prognosis. And we're taught in hospital that a patient's not dead until they're warm and dead. But a lot of these patients are going to be cold, because they're going to be in water. Can we prognosticate any of these patients? Is there anything we can do to figure out who's going to do well and not well? I've had a few of these questions, and I hadn't had a drowning case pre-hospital, so I wanted to look into it. About 2 days after I said to Jess I'd do it, I then did have a drowning case. So I'm going to base around, this is a case that I had with Jackie. We're going to talk a bit about that and some of the learning points that I've had from that case. So that's the plan of things we're going to talk about, a bit about terminology and definitions, about water rescue and drowning in New South Wales, how a water rescue job might go, the pathophysiology management and prognostication in drowning, and then base that around this recent case that we had. So, talking about drowning, there's been lots of confusing terminology and definitions over the time, and these are some of the terms that you might hear used, which we no longer use. And in 2002, there was an international conference in Utstein, which is in Norway, I think that's how you pronounce it, where they came to an agreement on the terminology. And because these terms were confusing, nobody knew what they meant, and even if you did know what they meant, the person you were handed over to probably didn't know what they meant. And in terms of research, it's difficult to compare and know what people were talking about. So they came to this consensus about what we should use. So all those terms are out. That said, on Air Maestro in 2021, trauma, we still say near drowning. So 2002, these terms have been out. And 2002, I looked it up, is when Nickelback, This Is How You Remind Me, was the #1 song of 2002. So it's a very good song, but we've probably moved on from Nickelback. And we should now be using the terms drowning incident. And drowning incident is, what drowning is defined as the process of experiencing respiratory impairment from being immersed or submersed in a liquid. And drowning incidents are classified into 3 groups depending on the outcome. So they're either fatal or they're non-fatal. And if they're non-fatal, they're either with or without morbidity. So that's all we have to worry about. And the only difference between immersion and submersion is immersion is when you enter a liquid and your airway stays above the water, and submersion is when you enter a liquid and your airway is below the water. So clearly submersion has a worse outcome compared to immersion. So they're the only things that we need to worry about. We don't need to worry about any of the definitions or any of the terms that have been used. So in terms of worldwide, drowning is a huge problem, and there's about 2 people who die every minute worldwide from drowning. Most of those are in developing countries, and in Australia, even though a lot of people, there's a lot of water sport activity, a lot of water recreation in this country, so there's a lot of people out and about, but we do have quite good drowning prevention in terms of lifeguards and swimming, people being taught how to swim in education, that kind of thing. So we do relatively well, but there's a yearly report produced called the Royal Life Saving National Drowning Report. And up until June this year, there were 968 drowning incidents in the previous year and 294 deaths Australia-wide. And that graph at the bottom, that bar chart, just shows the numbers, which perhaps are going up a little bit, maybe not significantly, are going up a little bit. And that map shows the number of deaths in each state. So in the last year that was reported, there were 99 deaths from drowning in New South Wales. If we look at New South Wales specifically, say 99 drowning deaths last year, 155 non-fatal drowning hospitalisations. The pie chart on the left just shows the age demographic, so most of these occur in 25 to 34-year-olds, so a group that probably quite, they're out and about doing a lot of recreation in the water, maybe high-risk behaviours, maybe drug, alcohol involved, that kind of thing. But that's the biggest group by age. And that chart on the right just shows some of the activities that people are undertaking. But essentially about a third of drownings occur in the ocean or in the harbour, and about and the rest of them occur in things like lakes, rivers, swimming pools, baths, that kind of thing. So it's not all just about these water rescues in the helicopters. There's a lot of these jobs, and there were 65 drowning incidents last year in southwest Sydney, so in our sort of local patch. So there's quite a few of these jobs that we're going to by road as well.
What's non-aquatic transport?
Which one are you looking at, sir?
On the activity?
Non-aquatic transport.
Yeah, I mean that might be driving your car into the water. Or I don't think it's a car wash instance. I'm not sure, to be honest, what that involves. So in terms of, so obviously that's New South Wales wide, but we're not involved in all of those cases. So in terms of the ones that we are involved with, I don't have any numbers for this, but talking to some of the paramedics, they reckon about 1 in 10 of our water primaries end up with a paramedic getting wet, as in getting dangling off a helicopter in the water. I don't know if that sounds about right from the paramedics in here, but what do you reckon, Cam? Less than that? More than that?
Got wetsuit a lot of times, don't know how many times, been in the water once.
In the water once, okay, yeah, so maybe less than that. Actually water primaries end up in water rescue from our point of view. So, so the majority of the time we're either called off or the patient's out of the water by the time we get there. And I've had about 4 or 5 jobs where I think I've been on tasked on water primaries, and the furthest I've got is the engines turning. And the quickest call off was about 10 seconds when they then saw the patient was out of the water. So I consider it a very lucky day if I see a paramedic in a wetsuit, because they look good. But the majority of the time they're not going to get in the water. This was Jess's job. This was a great job down in Wollongong Way, which involved 3 of our teams. A couple of weeks ago, wasn't it? So that's Jess on the back there, and that's Josh Taylor in his wetsuit. So he's on the beach. So he got close to the water. Sometimes we don't get quite so close. And I think our role as a doctor in this is to photograph the paramedic in their wetsuit out of water and put it on the WhatsApp group. So hopefully there'll be some photos put up on the WhatsApp group today. So in terms of the patients that we actually, these are jobs where we actually get to a patient. In the last 4 years, there are 178 jobs, and these are jobs that we've either ticked on the mission category as water, or in the diagnostic category on Air Maestro, we've ticked near drowning, or in the follow-up, there's been the terms drowning, immersion, or submersion used. So any of those jobs, there's been 178 of those jobs in the last 4 years, so average about 38 jobs a year. And a quarter of our cases are paediatric, so we go to more paediatrics than are represented in terms of the overall drowning burden, and that's probably because there's a lower threshold for tasking us to particularly 0 to 4-year-olds, which I think makes sense and is appropriate, but we go to quite a lot of children. And these patients are sick, so 38% of them we intubate, almost a quarter of them we pronounce dead at the scene, and a further quarter, 24 hours and 24-hour follow-up, are still in a high care ward, either most of them in ICU, there's a couple in CCU. So these are sick patients. So, is the video isn't set up, is it, Jess? On the, there's a video on the e-learning, the VLE which just shows the cabin setup, which is quite useful to review for the registrars, just in terms of getting your head around how it goes and looking at it every once in a while. But there's a checklist in each of the cages for the setups in Wollongong, in Bankstown and Orange, just to remind you if you do get a water primary. But just quickly going through it, this is what we're going to do in terms of our cabin setup. So wander leads are down, and I wondered why this was. I thought they're just going to get in the way and dangling around, but obviously the paramedic and the crewman are going to be on wander lead. We may or may not be on wander lead, which we'll come on to. And it's one less thing to do when they're up in the air with lots of other things to do, and you're not on the shuffle your seat around and disconnect it. So that's why we get them all down early. We're going to put our wide piece on as the doctor, because there's a reasonable chance that we're going to be winched to a rock shelf if the patient's out the water, and the paramedic's wide piece is going to be connected to the RSA. The water strops out, because that's what they're going to use to scoop out the patient. The water radio's on there, and that's not a special radio, which I thought it might be. It's just a standard radio, but it doesn't have the Nexus plug, so they don't have to use a helmet to plug into it to talk and listen to. So that's why we have that extra radio. And then we're going to put the DEA by our feet. And also, it's not mentioned on this, but it is on the video, that yellow loaf you can see in the back there, that contains towels to dry the patient, and also vomit bags. So that's going to be something that we might need. So you can have that by your feet as well. So just on the way there's a few things that you need to think about. Suction, we should have tested our morning checks anyway, but it's worth just checking you've got suction available. In our SOP, it says put the suction under the head of the mattress, but it's worth just checking that it's free, and if you pull it, it's not going to all come apart, because you might need to use it. Someone gave me a tip, one of the paramedics, of putting an eye gel in your pocket. Our SOP says that you shouldn't have the DEA open when the doors are back. I guess there's a risk of something flying out and hitting the tail rotor or something like that. So our SOP says don't open the DEA, although from speaking to people, it's perhaps not unreasonable if you're holding the DEA, it's restrained and you carefully can take out the BVM or whatever. But our SOP says eye gel out in your pocket.
Very uncomfortable paramedic sitting here hearing that.
What? So what's the answer, Cam?
Sorry to interrupt.
No, please do.
Like say, there's actually been 3 jobs. One deceased, one where I was mentoring someone else, and another that I did. So it's still not a whole lot of experience, but what tends to happen is that these jobs happen close to coastlines, and we land quite close to where the job's happening. So there's a very short transit from pulling the person out of the water to landing on an oval, and every person from anywhere around has come to that oval. And you're doing an outlanding with cars, people, all sorts of things, and you're banking, and it's all happening really quickly. And it's a really dangerous phase of flight. That was what was really highlighted to me in the last one that I did, was that the period between the patient coming into the cabin and us landing on a very uncomfortable period. And so adding flight coming out the door to that makes me feel very uncomfortable. So
yeah.
I'm not going to say don't do it, because your 7 cents might be different, but be very, very mindful about cabin security during whatever.
Yeah, so sorry.
There's like 2 phases. They're out the water and you're on the ground before you know it. And I think
Yeah.
basically all medical treatment happens when you're on the ground. I think realistically all you can do is position the patient on their side. And that's about it.
Yeah, in the
Okay.
air, you'll be doing nothing more than bagging the patient. You won't be doing any advanced airway or anything.
I think you can bag them if to achieve.
Yes, on their, as you know, they're wet, so you're not going to be doing anything electrical. And you'll often be dumped on a helipad at St George or Prince of Wales or something before you know it, rather than the local oval as well. So that affords extra opportunity to actually provide more advanced care. Then you won't get to do much in time.
But only if the door closes, then you can open it back. And that's the usual situation. The door closes 12 seconds after the paramedic's in, you get on with it. But try to keep opening things in the middle of the door opening exercise properly. And that's why the operating procedures here do that.
Okay.
And remember, there are an infinite number of possibilities. Yes, generally we do land immediately, and that's the usual situation because the patient's just off the coast, but there are infinite potentials. We could go out to a boat in the middle of nowhere, and that might be a long transit time. So thinking about various perspectives and potential situations is worth doing.
So I think for people who probably didn't hear any of that, so the general idea seems to be you're going to be landing generally very quickly with these patients, so you're not going to be able a chance to do much intervention in flight at all, and generally opening the DEA when the doors open is not recommended, just because of the risks associated with that, and you're probably not going to have time to do much anyway. So that seems to be the general consensus. So you may or may not on the way there take an IGO out. The SOP says you can take the BVM out and attach it, but we've decided we may or may not have time to use that anyway. And also in terms of doctor on wander lead, that's another thing that I've asked a few paramedics about, and that seems to be very specific to the pilots and the air crewmen, and that's something that might be worth briefing on the way as to whether or not that is something that they want you to do or you should do. But we're not Hewitt trained to be on wander lead, whereas the paramedics are. And also, I think it was GT was telling me quite a good tip that actually if we put our arm, as long as we're restrained in some point, then that's fine. So we can take our arms out of the shoulder straps, and actually when you do that, you've got a pretty good range of movement and with your seat sliding forward and backwards. So actually you can do quite a lot in terms of any airway positioning, or if you're putting an iGel in or BVM or whatever, then you can probably do all of that just with that. So it's probably not necessary anyway, and is an additional risk. But it's worth just talking about that in the way, because you don't want to be making these decisions when the doors open and the air crewman and the paramedic are busy and have other things to think about.
Yeah, I might say on that again.
Yeah.
So I guess before deciding that you probably could do those things, you probably should put some amount with the mannequin, because I'd say you probably can't do those things
Okay.
that effectively. So definitely one of our registrars a couple of years ago did pretty much the same job on 2 consecutive days. One on the lead, one in the seat. That was quite interesting to sort of debrief that afterwards about what can and can't be achieved. It's quite hard to achieve anything in your seat.
Oh, right, okay, yeah. Even with your arms out, you might not be able to.
You've never worked on one of those a lot. It's a very different experience from being in this seat. So I would be reticent. I've done a lot of time on one delay until I was open. I felt a lot more secure with jaws open in the seat. I think anyone would be saying you're held into your seat when you're on one delay. You haven't been a moving aircraft. I'd never.
True, I mean, the SOP does say that it's when the right door is after a certain
Yeah.
when the right door is shut.
And I don't know how many of the doctors here, like the paras and crew will generally immediately want to lead, so it's a restraint device, so you're not going to go out the door. I don't know how many doctors in their pre-morning checks, as I fly here, check, because a long lead and going out the cabin door, has happened, not in this contract, but it's not fun. It's very hard to get back in to an aircraft on the one lead from the crew and I've seen it. So it sounds exciting, but it's very hard, especially when you need points of contact, being able to stabilise yourself and do things in one lead. It's very, very hard. Brownie and Shay worked around to see how dynamic the para has to move around using the crew. There's 3 points of contact for using their knees. You never go through that.
Okay. So that,
One.
yeah.
Fun, sometimes, but it's not.
So for the people who the comments then were, we might not be able to do a huge amount in our seats. However, we're not trained as the doctors to be on wander lead, and it's not quite probably as straightforward as.
You should go on wander lead if you need to go on wander lead. Don't think you can't go on wander lead.
There's 2 competing needs, isn't it? Where, we obviously the aviation, they're high risk aviation jobs because there's a lot going on, and then patient care's also really complex and challenging, and the worst result would be an aircraft ditching into the water with 3 people on one lead in the back, but then the flip side is you've got to try and deliver patient care as well. So I suppose we're finding a balance point there somewhere.
So it's situation specific, and it's something to brief about.
From the seat to the mannequin and stuff.
Right, okay.
And then I'll see how it goes to people who can't deliver.
the training with us has been a sort of easy around Sim on this workshops. We're trying to revisit it again soon. But I think one of the key things, particularly for the registrars, don't practice that. Getting your wander lead, seems silly, but getting your wander lead, getting hooked up and doing that sort of, you need to be checked once you do that, but being able to do that independently in flight in a busy bay, like that transition here, you go from seatbelt to wander lead is very. That's one of the
crewman has headspace to check all
to do all that. So one of the discussion points around this is whether the doctor should start on wander lead in their job, and that's sort of been with all of these directions being poo-poo, but there's that that consideration as well around how much of a fat it can be when you're not used to getting onto wander lead, just to become more familiar with it.
And that
Bogged down here, but I just want to make sure everyone's clear that you shouldn't be on one leg and seatbelt at the same time. So it's quite tempting to say, well, the way I'd manage those, I'll cut my one leg now and stay in my seatbelt, which you shouldn't do. I'm sure you're all aware of it.
No. Okay, so not on one lead and seatbelt at the same time. Yeah. So it's situation specific, I think is probably fair to say, and it's something that you need to think about on the way, and you want to be briefing with the air crewman and the pilot and the paramedic on the way, and not deciding when the doors open and the rescue's underway. So in terms of what we might do on board, we've already said, and Gary said, that you don't have time to do much generally for these patients because you're going to land pretty quickly, and that's going to be the main thing you're going to do. But you may or may not give oxygen. We've got suction, which we may or may not use, and we'll talk about suction a bit in terms of management later. If you've got your BVM and your IGL out, then again, you and the patient's unconscious or in cardiorespiratory arrest, then you may use those if you have time. Chest compressions, I think, is something, from talking to people, is something that if that the paramedic and the air crewman might alternate between doing. The paramedic's probably going to be quite tired from their rescue. The air crewman's going to be perhaps helping with a landing site or something like that. So they might have other things, but you're going to try and rotate around and do that. And you're going to land as soon as you can, and anything else is going to be done when you've landed. And then in terms of if the patient's in cardiac arrest, you're going to then go into your standard thing. You're going to try and put your defib pads on, but you have to make sure that that's safe to do. So the patient's going to be wet, the paramedic's going to be wet, the cabin's going to be wet. So you're going to dry the patient, but you might have to remove them from the helicopter to do this safely and defibrillate them. And if so, that might be onto a road crew striker stretcher, or it might just be onto the ground. But most drowning patients are not in a shockable rhythm, and it's only 6% who are in a shockable rhythm. So most of these patients, and the management is predominantly the priority is to give ventilation breaths rather than airway defibrillation. So just moving on to our drowning case that we had, myself and Jackie had a couple of weeks ago. It was on an evening shift, and it was in Raby, which you can see banks down the heart there. Google obviously knows how much I love coming here. And Raby at the bottom left there. So about a 25 to 30 minute drive, and the bat phone goes off, and it's a 1-year-old who's found unconscious in a swimming pool, and they're doing CPR, and that's all we know at the time. It subsequently turned out that the granddad found the 1-year-old in the swimming pool unresponsive. He hadn't been seen for 20 minutes at least. Granddad pulled him out of the swimming pool. The call taker was trying to talk granddad through doing chest compressions, doing CPR, but he was in bits and not able to do that, so not able to do any resuscitation at all. But he did at some point manage to get the attention of a neighbour, who then came over, and then the neighbour was performing effective chest compressions when the road crew got there. And the first road crew on the scene got there 10 minutes before we got there. So this is when we get there, the patient's in the back of an ambulance. They're running through their coach. One of the ICPs has the laryngoscope in the mouth and is just about to intubate. Hasn't intubated yet, but just in the process of intubating. So a bit of a critical moment for us to try and join in and help. They don't have any vascular access, and the ICP didn't have any IO stuff available for some reason. I can't quite remember why, but didn't have any intraosseous stuff. So I helped the ICP with the intubation, and then once that was secure, put an orogastric tube down and tried to decompress the stomach. Jackie went and got our IO kit and put an IO in, and at that point the other paramedic managed to get a cannula as well, so we had 2 points of access. And Jackie also brought over the Hamilton ventilator, so put the patient on the ventilator during this resuscitation, and out of interest with a PEEP of 5. He was originally in asystole. We gave adrenaline, and he went into a sort of agonal bradycardic rhythm and then PEA. He had a total of 11 lots of adrenaline during our transfer, and we took him to Westmead Children's. So just looking back at the map there, where we were, Raby, we were close to Campbelltown, about 10 minutes drive. We were about 25 minutes from Liverpool, and we were about 35 minutes from Westmead Children's Hospital. So we went to Westmead Children's Hospital. So it was quite a long drive, and by the end of that, we'd had a total of 66 minutes of cardiac arrest, so 10 minutes with the road crew before we got there, and then 56 with us by the time we handed over into ED. Patient temperature is 35.7 and blood sugar of 6. And then when we get to ED, he's still in PEA. They get ROSC after about 20 minutes, so now we're at 86 minutes of low flow or no flow time. And then about 5 minutes after that, he goes into PEA again with a further 5 minutes of CPR. So in total, about 91 minutes of low flow or no flow sort of time. The original blood gas, the pH was unrecordable. And then on the second one, it was 6.57 and a lactate of 17. And then he goes to PICU after that. I'll talk about the outcome a bit later, but some of my thoughts after that were, when we got there, the resuscitation was going on for about 10 minutes, but should we have given rescue breaths? I put him on 5 with PEEP. Was that enough? Should we have given more? I put him on the Hamilton ventilator during the resuscitation. Should I have done that, or should we have continued on a BVM like we normally do? The mum was around. Should we've got her to witness any resuscitation? Should we have taken her with us? And should we have considered ECMO or pre-phone through and mentioned that as a possibility? So that was some of my thoughts. And then some other people's thoughts, discussing it afterwards and talking at coffee and cases. And I had an email back when we were following up this patient from Westmead Children's, and one of the doctors there said, why don't we go to Campbelltown? So did we go to the right hospital? Should I have done an echo during the resuscitation?
Or are they just trying to test it?
I think that's it. I mean, if you would have made the decision that you were going to cease resuscitation, that would really good.
It came from the perspective that there was no output at Westmead, and they thought that they were 35 minutes for the child in cardiac arrest.
They should really see children to
Cardiac arrest, yeah.
We'll talk about that a bit later. And so should I have done an echo, and should we have stopped at any point? So just quickly talking a bit before we come on to, we'll look back at those thoughts, but just bear them in mind. But talking a bit about the pathophysiology and the management of drowning. So I would have thought drowning is pretty straightforward. Your head goes underwater, you can't breathe in air, and you become hypoxic and you die or don't. But there's slightly more to it than that. When we become submerged underwater, we hopefully hold our breath, and you guys can probably hold your breath in ambient air for about 60 to 90 seconds. If you do it underwater, it's probably about 45 seconds on average for the average human adult. In cold water, it can be seconds, and then you will take a deep breath. There is this breath hold, this diving reflex, which is a triad of breath holding, bradycardia, and peripheral vasoconstriction, and that helps to perfuse your heart and your brain. And all babies have this reflex, and as we get older, that goes away. So about 2/3 of adults have it. But if you get submerged in cold water, this reflex can be slightly protective. But ultimately, you will try and take a deep breath. You may or may not go into laryngospasm. Children more likely will go into laryngospasm, which might protect them from aspiration. But again, when you become increasingly hypoxic, that will break, and then if you're still underwater, you'll aspirate. And when you aspirate fluid, if it's fresh water, it's generally absorbed pretty well into the pulmonary circulation, but in that process, it washes out all your surfactant. So you lose your alveolar surface tension, you get collapse, atelectasis, you get massive shunt, reduced pulmonary compliance, and you become hypoxic, hypercapnic, and generally people will go into cardiac arrest within about 2 minutes of submersion. If it's salt water, then it has the same effects, but because of the increased salinity and tonicity of the water, you can get water being drawn into the alveoli. But again, you're washing out your surfactant, you get atelectasis, there's no area for gas exchange, you become hypoxic, and the effects are the same. So in terms of our management, it's all going to be the same. There's also a slight difference in terms of cold and warm water, and if you're immersed in water, so your air is above the water, you still, obviously, if you're drowned, you by definition have respiratory impairment, but you can survive, obviously, in warm water for a very long time, and 27 degrees, so if you're having a bath, you could sit there for pretty much indefinitely without having any respiratory impairment. But as water becomes colder, then we can have respiratory impairment from immersion, and in terms of from the pathophysiologic responses, cold water is actually defined as 15 degrees Celsius, which sounded to me quite warm. But actually, I don't go out in 15 degrees Celsius and worry about getting hypothermia. But water conducts heat 25 times greater than air, or faster than air, and that's why we get hypothermic more quickly, and also why when I go to the beach in Coogee and it's 18 degrees Celsius in the water, that feels really cold, when 18 degrees Celsius in air doesn't feel that cold. So in terms of if we're looking at cold water immersion, and with 15 degrees Celsius being the cutoff for that, we will get patients in lakes and in rivers around New South Wales who will experience this. There's 4 phases to the cold water immersion response. You get this cold shock response, which is where you get uncontrollable gasping and ventilation. You lose control of your breathing, and that you can aspirate water during that time. And particularly even if you're immersed rather than submersed, if you're having waves crashing over your face, then you can aspirate during this time. You also get this autonomic response, so you get sympathetic drive, you get a catecholamine surge that can precipitate arrhythmias, myocardial infarctions, that sort of thing. And all this response occurs in the first couple of minutes, and so the advice, if you're in cold water, is to relax, try and float, extend your arms and legs, and keep your airway out of water during this time, and allow the 90 seconds for this response to pass. And there was a campaign in the UK a couple of years ago by the RNLI about describing this. So if you go into cold water, you just try and float for those first 2 minutes. After that response passes, you then get superficial tissue cooling, which is essentially your muscles and nerves, so you get reduced nerve conduction, your muscles become less effective, so you reduction in your strength, in your dexterity, in your ability to swim, importantly, and tread water. And then you get deep tissue cooling, which is essentially your classic hypothermia response. So when you get down to sort of 34 degrees, you might become a bit disorientated, a bit lethargic. Down at 30 degrees, the average person will lose consciousness. 28 degrees, you can get spontaneous VF, and 24 degrees, death. And those temperatures obviously vary a lot, but they're about the averages for the kind of things you get at certain temperatures. And there's also this phase in the what's called the post-immersion or circumrescue time, when and part of this response is when we drag people out of the water vertically who've been in the water, they can get sudden cardiovascular collapse, and that's because you've had a patient in the water with the external hydrostatic pressure which is suddenly lost, so you get your increased venous capacitance. You've also got a cold heart which can't increase contractility and is bradycardic, so you can't increase your cardiac output, and you suddenly transport them vertically into the helicopter, which we obviously have to do. We don't have another way of getting them in. But so it's a not uncommon response to have, where you have a patient who's conscious in the water and you bring them up to the helicopter, and it's well described that by the time they come to the helicopter they may be unconscious or in cardiac arrest, and that's part of that sort of response. So that's the pathophysiological processes that occur in drowning. In terms of the management, generally our patients are either going to be really quite well or very unwell, and the well ones are generally the ones who've been rescued. They've not suffered drowning until there's not a respiratory impairment, but they've been rescued because they've been stuck out and they just needed to get out of the water. And so which of these patients need to go to hospital? Well, a lot of them will do. There's this graded, there's these grades described of drowning, and if you have a grade 1, so you have a bit of a cough but no other respiratory symptoms, then you in theory have a 0% mortality and you can be discharged with safety netting advice. But if you have any respiratory symptoms at all, any crackles, any wheeze, increased respiratory rate that doesn't settle down, obviously if you're hypoxic, anything like that, then you have to go to ED to be observed for 6 hours. And that's because the drowning process can go on for that sort of time as fluid shifts change and things like that, and you get water drawn into the lungs and pulmonary edema. So they need to be observed for at least 6 hours during that time. The unwell patient, the patient in cardiac arrest, and I've been through the sort of main players in terms of resuscitation, like the Australian Resuscitation Council, Resuscitation Council UK, and the American Heart Association, and there's a few different themes that come up. We used to talk about using the Heimlich maneuver to help empty the stomach out. That's a bad idea because, of course, it can cause regurgitation aspiration, so that's no longer recommended. A few people have talked about postural drainage, and apparently when some of the lifeguards rescue these patients, they will take them out essentially head down to allow postural drainage of the airways. Again, that's not recommended in the guidelines because it delays time to ventilation. And there was a study in Brazil, they used to do it where if you're on a beach, they put them head down on a slope, and they found that the patients who were head down as opposed to flat did worse. And that was thought to be because of regurgitation and aspiration. But I suspect also probably if you're ventilating someone head down, you're going to be less effective, and that's probably going to contribute to a poorer outcome. So we don't do postural drainage or Heimlich manoeuvre. Oxygen's obviously good. PEEP is good, particularly in terms of the pathophysiology we mentioned, in terms of the reduced compliance and the atelectasis. And if cardiac arrest occurs, then it depends on which country you're in, but Australia and the UK say give 5 rescue breaths. In America, they say give 2, but this is a deviation from our standard ALS where we do high quality chest compressions and near defibrillation is the priority. In drowning, it's giving your rescue breaths. And if they don't respond to rescue breaths, which if they're in respiratory arrest, they normally do, then you start chest compressions. In terms of suction, suction is thought to not be generally a good thing to do because if you suction the fluid, it will just reaccumulate and it's just something that you're not going to get on top of. So generally the advice seems to be if you've got things in the airway, if you've got fluid in the airway, then you can suction it out for 5 to 10 seconds, but don't keep going. Suction to help you intubate the patient when you're looking down, and suction out any aspirate or any regurgitated stomach contents, but otherwise don't keep suctioning or tracheal suctioning because that will just continue to reaccumulate, so it's not something that's advised. But an NG tube or an orogastric tube, something to decompress the stomach, is a good idea. And PEEP is advised for the reasons we've mentioned. The numbers vary. Some suggest starting off at 5, some suggest you need to be at higher, around 15 to 20. If they're in cardiac arrest, they say go lower because of reduced venous return, but there's no hard answer, but PEEP is generally a good thing. And in terms of further down the line, antibiotics, steroids, and exogenous surfactant are all not proven to be effective unless you've antibiotics if you've aspirated contaminated water, but otherwise they're generally not given. ECMO is to consider in prolonged resuscitation, but the only good evidence is for it in patients who are profoundly hypothermic, and it's not proven to be particularly that useful in other cases. And just bear in mind your hypothermia algorithm anyway in these patients. So in terms of if they're less than 30 degrees Celsius temperature, that core temperature, then you can give 3 shocks. But if they persist in a shockable rhythm, you don't give any further shocks until they are 30 degrees Celsius. And you don't give adrenaline until they're 30 degrees. And then between 30 and 34 degrees, you double the duration, the interval between your adrenaline doses. In terms of the prognosis, overall, it's very poor. And there was a big study in America, which in Washington State over 20 years, which showed that 78% of drowning victims who went to hospital had a poor prognosis, either death or severe neurological disability. There's this Orlowski scale, which helps to predict outcomes. And it gives you 5 features. And if you have 3 or more of these features, then you have just a 5% chance of recovery. If you have less than 3, then you have a 90% chance of a good recovery. So our patient we mentioned before was less than 3, was submersed probably for more than 5 minutes, and there was a delay to CPR. We don't know how long, but there was a delay. He was comatose on arrival to ED, and his pH was less than 7.1. So he certainly had 3, probably had all 5 of those features. So the prognosis was probably not going to be good. And then the International Liaison Committee on Resuscitation in 2015 were asked to publish advice, predominantly for search and rescue organisations, on how we might be able to prognosticate these patients. And they looked at these 4 things and to decide whether or not we could determine which of these patients we should cease resuscitation on and not transport to hospital. And in terms of whether or not they found they made any difference, duration of submersion, do you think that made a difference to outcome? Yeah, I mean, it did. As you'd expect, the longer you're under, the worse you do. And generally, they found that their advice is if you are submersed for less than 10 minutes, you have a reasonable chance of a good outcome. If you're submersed for more than 25 minutes, everyone the literature they examined, you had a universally poor outcome. So, less than 10 minutes, good. Greater than 25 minutes, poor. Age, would that be a good prognostic indicator? Does anyone think? No. Age wasn't. If you were under 5, you did poorly. If you were aged between 5 and 15, you did slightly better. And then as you got older, with comorbidities and other things, you did poorly. So they didn't think that was something you could use to prognosticate. saltwater versus freshwater, again, they found a slight trend to increase in good neurological outcome in saltwater aspiration, interestingly, but that was thought to be very poor quality evidence and not something that we can translate into clinical practice. And water temperature. So again, they didn't find an increase in or improvement in outcomes with cold water submersion or immersion. They looked at big studies, and they didn't look at small case reports and case series of the extreme survivors of patients who have gone into very cold water and done very well, of which there are a few. So they did comment on that, but they said that water temperature in itself they couldn't recommend as a prognostic indicator. But then this study, which did look at those extreme cases, they found that you can see on the graph there the longest submersion time, and these are all patients who made a full neurological recovery. The longest submersion time was that top dot you can see, which is at 5 degrees Celsius water temperature, and that was a 2-year-old who was submersed for 66 minutes and made a full neurological outcome. In warm water, there is somebody there who was submersed for 22 minutes and made a full neurological outcome. So based on that, there was this idea that you can split in terms of prognostication water temperature into icy cold, i.e. less than 6 degrees, and greater than 6 degrees. We're rarely going to be in the less than 6 degrees here in New South Wales, but so our water temperature greater than 6 degrees, they suggest that survival is extremely unlikely if the patient is submerged for longer than 30 minutes. So they suggest that's the cutoff, when if they're submerged for longer than 30 minutes, you switch from a resuscitation approach to a body recovery approach. If it's cold water less than 6 degrees, which obviously we don't have a thermometer and carry around, but if it's icy cold water when you touch it, then in theory they might be able to survive to 90 minutes. The problem with that is the key thing with the temperature is it needs to be your core temperature, your brain temperature when you go into cardiac arrest. So you need to cool very quickly. So it's not just your body temperature when you're recovered. The main determinant of the prognosis and the neuroprotection is your core temperature at time of cardiac arrest. And so the reason why some of these people have done well is because they're thought to aspirate this icy cold water, and that can reduce your carotid blood temperature by apparently 7 degrees Celsius in 2 minutes if you're aspirating cold water. And then the people who did well were generally young people with big, or infants with big or small surface areas in terms of superficial cooling after that initial cooling phase. So they had a cold core temperature when they went into cardiac arrest, but obviously we don't know that. We don't know that at the time. So in terms of, there are some people have tried to give us an idea about how long we should do CPR for in these patients. The American Heart Association say that any patient with drowning should be transferred to ED because they might have a good outcome if they're cold. And they only say to stop if there's obvious evidence of death, like they mentioned decapitation or hemisection or lividity or things like that. But I think probably we can maybe do a bit better than that and prognosticate slightly better than that. Some articles have suggested if someone is normothermic and they have not got ROSC after 30 minutes, then they universally do badly. Their transverse five was very slim, and the ones who do survive will have a very poor neurological outcomes, so they suggest stopping at 30 minutes. And if your patient is hypothermic, then one article suggests warming them to 30 degrees, and then if they remain in cardiac arrest or asystole for 20 minutes, then that's at the point in which you should stop. So it's not clear, but there are just some guidelines out there as to when we can or cannot prognosticate these patients. But our patient was 66 minutes when we dropped the patient off in ED of low flow or no flow time. So it suggests that he's not going to do very well. So if we go back to our case, the patient day one was having myoclonic jerks. He then went into DI. His CT head showed features of profound hypoxic ischemic injury with multiple established infarcts and evidence of cerebral edema. His EEG showed severe hypoxic encephalopathy. And 7 days later, so a week later, he was diagnosed with death by neurological criteria, so brainstem dead. He was baptized the morning before his brainstem death testing, and the family consented to liver and lung organ donation. The liver was donated. There was no suitable recipient in Australia and New Zealand for the lung, but he donated his liver. So just finally going back to the thoughts that I had earlier on, and having since done a bit of reading around that, should have given rescue breaths. I think I probably should have done. I know CPR had been going on for 10 minutes by that point. I should have certainly have confirmed whether or not that had been done, because I think, imagining in my head that these lungs are collapsed down, and once we put the tube in, I think it probably would have been a reasonable idea to try and re-recruit and provide a bit of positive pressure to those lungs at that point. So I think that might have been a good idea. Was 5 enough PEEP? I think probably not, and I know the evidence, there's no particularly strong guidelines either way, but I think, again, given the pathophysiology, I think if I could do this job again, I would probably start at least at 10 and maybe go up to 15 or so. Using the bag valve mask or the ventilator during resuscitation, I don't know if anyone has any strong thoughts on this. I've done a bit of reading about it, but does anybody think it's a bad idea or a good idea, or have any particular feelings either way?
Just need to turn the P-max on the alarm settings up to 60.
Yeah, and certainly the ventilator was alarming, but we actually had, unfortunately it wasn't on the Zoll, it was on the life pack, but we had a good end-tidal CO2 trace, and we were getting good end-tidal CO2 numbers. You can see there, sort of starts off around the 60, 70 mark, and then by the time we were getting to ED, it's down at the sort of 40 mark, which told me that we were getting air in and out. We'd got rid of our gooseneck and we'd put the paediatric filter on, so I don't think that was all dead space, and we were getting a reasonable amount of air in and out and reasonable chest compression. So I thought we were ventilating okay, and I had Carol's voice in my head from I think induction or a previous coughing case sent to the ventilator, and I'm taking this out of context, but saying the ventilator is better at ventilating than we are with a bag valve mask. And I thought, well, the main problem is ventilation, and if the ventilator is going to do a better job, then it might be a good idea to put them on that. And we had a 40-minute drive, and in terms of freeing up hand space, and I thought that might be a reasonable idea. Looking at the literature, people have looked at this. Apparently, doing chest compressions on a mannequin, you get the equivalent tidal volumes with a ventilator as you do with bag valve mask ventilation through an ET tube during chest compressions. And people have done studies in real cardiac arrest, and apparently blood gases are equivalent in patients in cardiac arrest who are put in a ventilator versus bag valve mask ventilation. So I think it probably doesn't really matter. But I think I probably would have gone on the BVM, or maybe, because I think the main problem was ventilation. I probably maybe could have generated higher airway pressures to do that. Should the family witness the pre-hospital resuscitation? I think not. I think families seeing resuscitation is a good thing in paediatrics. I think we know that. But having spoken to Ian about it afterwards, I think that's in the context of in-hospital resuscitation, when you have a dedicated nurse who is sat with mum or dad and is talking through what's going on. I don't know if having mum in the back of or in the ambulance would have been a particularly good idea at that point. And mum did get to witness some of the resuscitation at the hospital, which hopefully might, because that reduces post-traumatic stress for parents and things. So maybe that might help in some way. But I don't think, on reflection, that we should have done that at the time. I think we had other priorities to do.
I think it's very situation specific, and one of the things that families sometimes take away if they haven't been there when their child died, or when they perceive that the death happened. So if there was any chance that you could go to resuscitation during transit, then I would say you should take them and take the parent with you.
Right.
That's one of the things that parents really struggle with, is that they perceive that their child was without them in their last moment.
Okay. So from that was just if you're thinking the child might die during transit, or then it would be worth getting the parents involved, because it's very traumatic for them to not thought that they were there when their child died. Should we have considered ECMO? No, I don't think so. I don't think he wasn't that hypothermic. I don't think that would have made any difference. Did we go to the right hospital? I think so, although as Jimmy said, and having talked about this, so the road crews SOP is, if you've got a child in cardiac arrest, you go to the nearest hospital. I didn't realise this, so I thought automatically we would just go to Westmead. At the time, we didn't, obviously we'd been doing CPR for 10 minutes when we got there, and we didn't know the prognosis at that point, but I think it was reasonable to take a patient somewhere where there was a paediatric ICU. And subsequently, this patient has, they were in ICU for 7 days. That's given the family a chance to come to grips with things, perhaps. They've been baptised, they've donated an organ, so there's been maybe some positive, the mum's been able to witness some resuscitation. There's been some positives that maybe there wouldn't have otherwise been. So I think probably going to Westmead Children's was the right decision. Should I have done an echo? Yes, I think so. I think I'm happy with the role of echo in cardiac arrest. What I'm not quite happy with as an anaesthetist is the role of my echo in cardiac arrest, and particularly in paediatrics. But I think if I'm asking a specific question, I think it would have been a good idea. And Jackie asked me if I wanted the ultrasound, and I said I didn't think I was going to add anything at that point. But maybe particularly in terms of the PEEP, that might have helped me in terms of the reason I put 5 of PEEP on was I thought we want a bit of PEEP, but I don't want to reduce the venous return in someone who's in cardiac arrest. Perhaps if I put an echo on and the IVC wasn't completely squashed, maybe that would have, given me a bit more confidence to put the PEEP up or something like that. So it might have helped me answer some questions. So I think yes, I should have done that. And should we have stopped resuscitation? The outcome was always going to be poor, but I think for the reason I mentioned before, in terms of family and coming to terms with and organ donation, I think it was reasonable to continue the resuscitation. And finally, the final thing I want to say, and I know it's interesting listening to Abs and Jeff talk this morning about it, but just to know, so the next day I had a text message off Chris Partiker, who, just to check in on me, Ian Ferguson phoned, he was a DRC and he'd seen the case report, the case sheet, and so he gave me a call and we had a chat through it. And it was something, what I've said before resonates with me. I felt at the time, I felt quite good about the job, which I thought was strange because this should be a very upsetting case. But when I went home, I thought that went okay. And it was only the next day when I then saw my kids who were similar age, and I thought that must have been really pretty terrifying for that poor 1-year-old. And imagining what the family have gone through, that's when I thought this really wasn't a good case, and I started to think about some of the things I already talked about, and did I do the right thing, and could I have done anything differently? And as Jeff said, I didn't think I particularly needed to talk through anything until Ian phoned, and then actually he phoned and I said, no, I'm fine. And then half an hour later after the phone call, I felt a lot better, having got a lot of things off my chest and discussed a few things. So I think that was helpful. So there is a lot of support out there, and that's been great in terms of the clinical side of things, but also liaising with the hospital, and there's going to be an M&M that we're going to be involved with to debrief even more. So there's lots of support out there, so don't forget about that. So just in summary there, the few things we talked about is our involvement in the water rescue and drowning, and maybe how water rescue might work, and the conversation we've had here have been very helpful because there's clearly a few things that are unique to this job that we need to think about and we're thinking about before the doors are open. We talked about management and prognostication of drowning, and then also some of the learning points from that case. And that's it. Is it coffee time now, Jess? Is it? Yeah. Okay. And what time do you want people back?